Hi, and welcome to the show. Subscribe at kevinmd.com/podcast and get CME for this episode by clicking on the CME link in the show notes. Today, we welcome back Paula Muto. She's a vascular surgeon, and today's KevinMD article is Panic Button, Escaping the Broken Healthcare Escape Room. Paula, welcome back to the show.
Thank you, Kevin. Thanks for having me again.
Paula's been on multiple times. Go to kevinmd.com/podcast to search her name and prior episodes and hear her story. But today, let's jump right into her most recent KevinMD article, Panic Button, Escaping the Broken Healthcare Escape Room. Now, for those who didn't get a chance to read this one, what's this one about?
So all of us, or many of us, have done escape rooms. They're very popular these days, for building team. Families do it. They do it for team spirit and so forth, and cohesion. And so the concept of an escape room is you go into this impossibly strange place and you put all your brains and your power together, work together to solve the clues. So I think it's very much like the healthcare system. We have so many smart people, policymakers, physicians, writers, healthcare gurus. We have so many smart people trying to fix the system, but we can't fix it. We can't fix it. So the question is, are we in an escape room without an algorithm or a clue to get out? Somebody actually, when I published this paper, said, maybe someone's inside the room with us that's sabotaging us. But I actually think it's the former. I think, we really have to ask ourselves, we're trying so hard to fix a system that may be unfixable. And that's what the article is about. And it comes in the wake of a major health system in my state and the hospital that I work at. And it's a national health system that declared bankruptcy 4 days ago.
All right. So let's extend an analogy. You have all the players in this healthcare escape room. You have the physicians, the administrators, the policymakers, and the patients. Tell us about some of the puzzles that they need to solve to potentially escape these rooms from your perspective.
So I think that looking at, you always look backwards to see how did we get where we are? And, and do we need, what step along the way could we have done differently, or do we need to repair, right, to get to the next level? And I think that it was built this way from the beginning. When you look back at the origins of the Affordable Care Act and the way physicians were written out of the equation, many people don't know that from a business perspective, physicians were not allowed to own. Own or operate like a clinic, surgery center, multi-specialty group. It sort of set the stage for the fact that we needed to have a business partner if we were going to do anything at scale. So it sort of like from the beginning pushed the doctors out of the equation, and then you kind of built the system where you have the insurers who are controlling the price of the medications we prescribe. They control the price of the admission to the hospital. They control the price of literally everything. And it's a fantastic positive feedback loop, right? As long as you keep fueling it and you have government tax subsidy fueling all of it, that you can create an amazing business model for this, for healthcare. But it forgets the fact that you forgot about the delivery piece. So I think that we have a system now that's on a positive feedback loop, and that it's really hard to get off of this without really taking down or understanding or put limitations on the insurers, put limitations on how the tax dollars spent. And I think to do that, you have to understand it.
Yes. So the fact that it's very difficult for physicians to operate independent clinics, surgery centers, things like that, what are some of the downstream effects of how that potentially affects patients?
So if you think about, just take a practice, like even my practice, right? Here I am, I have a vein center and I'm an independent practitioner. So now, I have a payer mix, always the same. My patients now have high deductible plans because their employees used to pay everything. Now they pay less. Now I have to chase my patient down. And the insurers have been behaving badly. You have like Change Healthcare, how you have all these things that happen. So now you come in, I do your surgery, I get pre-approval, I get authorization, I do it, I hire the equipment, the personnel, and everything else and do it. I take care of you. And then I now don't get paid. So, for all variety of reasons, right? Or the patient can't pay it. So now I can't I can't like do the next case.
Hmm.
And I can't do the next case. And I have to make my payroll. I have to pay my malpractice. I have to do all this. And I'm like, oh my gosh, it's just getting, this equation so hard. Then someone comes my way and says, hey, we understand that, Dr. Muto. Why don't we just like, we'll buy you and we'll
Hmm.
buy Dr. Fo and we'll buy
Yeah.
Dr.
Yeah.
Jones and we'll, and we'll put you all together and we'll group together and we can create this entity. Now, I would say like maybe I can combine with other doctors and do the same thing, except that again, the Affordable Care Act limits you sort of that 49%. Okay, so now we're all together, right? Now we're all together, and next thing you know, you've sold to say a private equity
Yeah.
backed. They have capital. You're like, this is great. They're paying for everything, and then they say, well, you need to buy all of your equipment from here, not here. You have to see your patients starting at this time and not that time. You're not allowed to do 2 procedures in the patient, even though the poor patient's there. You open the catheter, you can do it. No, we're going to get paid better if you do it twice. So next thing you know, your practice, your clinical decision making is being driven by a revenue model. And this is sort of how it happens, right? It happens innocently enough that you can't pay your bills, and then next thing you know, you're employed, and next thing you know, you're on this, you're enabling this system, and so I think that's sort of how we got here, right? And I think a lot of it is because we've kind of given into this model that the insurers have dictated to us through all of these other tentacles, and that's why I think the entire system is rigged.
Yeah, it sounds like physicians today, they started with giving up a lot of their control. They're disempowered, right? And not only can they not have these independent surgery centers or vein clinics, it makes it very difficult, but fewer and fewer physicians are even in private practice, right? They're in some type of employed model and they give up that control. And if that employed model gets sold to, say, private equity, it further disempowers physicians. So it sounds like you said, that feedback loop that takes away more power from the physicians.
I think, and the interesting part of this is they talk about corporatization in medicine. Like, we're in this corporate model where we don't answer to our patient, we answer to our boss who,
Yeah.
but now, and New England Journal had the article, financialization.
Hmm.
It's not corporatization, financialization. What does that mean? It means that you're not answering to your boss, you're answering to a stockholder. In other words, the entity itself has a value that is being bought and sold far from where you are. So that your business, your service, the success of your practice could fuel a Toronto's teacher pension. Just think about the concept of healthcare dollar comes into your hospital or your practice, and it doesn't get reinvested in your team, in your community. That may be a poor community. You might be able to reinvest it so that the next patient's free because the next patient needs it badly but can't afford it. But you can't balance that anymore, right? Because that money that comes into your practice is now immediately sent up the ladder and out into a private equity investment. And people think, oh, it's buying a yacht. It's not buying a yacht. It's fueling college endowments.
Hmm.
It's fueling bus driver pensions. And that is, I think, the question is, do we want the healthcare dollar reinvested that way or reinvested in the community they serve? And I think that if you read the front page of the Wall Street Journal today, a very nice article by Melanie Evans about a poor person who wants her daughter to get tonsils, and the surgery center is asking for payment up front. I completely understand that. But here's a woman who works, who has a health plan. The child needs an operation she's going to get once in her lifetime, and she can't afford it. Like, something really doesn't make sense there, because maybe in the old days that surgery center knew that Blue Cross patient that came in was already paid, so that second patient that came in that had limited means could be done at a different price, right? We always had that give and take because the money was reinvested, right? The money was reinvested in the
Hmm.
small, in the community it served. Now that extra Blue Cross payment is going off to fund something else. And I think that's where the issue is. The reappropriation of healthcare dollar, and the healthcare dollar is limited, it is precious, it is tax subsidized, and it should not be reinvested except in healthcare, in delivery of healthcare.
So let's talk about potential paths forward, right, to solve some of these puzzles, to escape that proverbial escape room. You mentioned about physicians banding together, but realistically, you know how difficult that is because physicians, they're kind of siloed. We don't have a lot of business training. And our adversaries, let's use this analogy, our adversaries, they're kind of trained all their lives in business and finance. So what hope do physicians have to escape this system? Because we're already, as you said, so far in the weeds, so far in the trenches of the financialization of healthcare.
So they always say doctors make bad business people. And I'm going to say the corollary, business people practice bad medicine. And we know that now. So
Mhm.
what they're doing isn't working. So that's the first thing, right? And everybody understands. It's not even a debate anymore. Outcomes are bad, costs are high, and at the end of the day, the people who are purchasing the medical care are not happy, right? The employers, the patients, they're not happy. So I think that is true. I think that what we need to do is doctors cannot unionize or have not. Although I will say that I think the first doctor union is going to occur in Massachusetts.
Mhm.
The trial, not through the Steward thing, but the MGB merger is wreaking havoc.
Mhm.
Once again, consolidators, business people. I mean, if you look at the board of MGB now, it's a franchise owner, football franchise owner, it's a construction
Yep.
person, and it's a investor. I
Yeah.
mean, how are they qualified to make safety decisions on patient care?
Yeah, and just to explain for those listeners who may not be from the local area, when you say MGB, you're talking about a Massachusetts General
Massachusetts,
Hospital and Brigham and Women's Hospital merger that is causing all sorts of havoc.
right. And they've been merged through the partners network anyways,
Mhm.
but they're just sort of bringing it to another kind of, again, these levels. And you can say, Kaiser, these are giant nonprofits and they behave in the same playbook as the profits. I mean, at this point, but the concept of these, again, putting all these services together, doctors can't do their job. You talk about it all the time on your program, people really honestly talking about burnout and moral injury. It really has come to that point where you are asking permission to transfuse a bleeding patient
Mhm.
because we have to make sure that transfusion is not just covered, is it economically a good decision? Is it going to make us money? It's not that it used to be, is it covered? Now it's just, is it going to be profitable? And I think that that's just not morally correct, ethically correct,
Mhm.
and medically unsound. So I think that the union issue is interesting. It sort of saddens me a little bit to think that doctors have to be labor in a hospital and that the leadership of the hospital is in opposition.
Mhm.
Like, why would you go to a place where the doctor and the hospital are in opposition to each other, right? It sort of doesn't make any sense. But I do think that we're coming off that curve, that bell curve. Patient doctor, like I don't know what's going to happen to the 11,000 Steward employees
Mhm.
if Steward can't land on its feet in Boston, whether those doctors are going to try to go independent. I think it would be fantastic. I think in the short term, what could be done is supporting independent doctors, either with tax incentives. I think that there is support at the highest levels in Washington over anti-consolidation, right? People don't like consolidators.
Mhm.
I think that in the short term, also all network restrictions should be banned. If you are a qualified physician and you take Blue Cross, you can take a Blue Cross patient from anywhere on earth. End of story. No more network restrictions because that limits access and it also causes a lot of cost at the point of care for both the patient and the doctor. And I think banning network restrictions in this emergency when you don't have access is a really important measure. And I think that lawmakers can do that. I think long term, the whole system should just be eliminated to a single currency. We should have a currency. I mean, you travel through Europe in the
Mhm.
old days, you'd go to France and have a franc, and then you'd translate your dollar into a lira and then to a Deutschmark. And think of all the cost. That's exactly like our healthcare system. We have all these different players with different currencies. But when Europe went to the euro, it was really a good idea. It saved billions of dollars, right? Because then everybody knew what their token was worth. So that when I go to, use my that operation's 100 tokens, your employer pays 50 of it, my employer pays 75 of it. We know the cost of it.
Mhm.
It's standardized. Standardizing like the healthcare dollar on a currency, I think goes a long way to making so that when you go see your primary care doctor, you whip out your insurance card, it has a computer chip and you go ka-ching, just like Toast, you just pay
Yeah.
for it. The transaction's instant, the doctor's paid, the fee is made, everything is done, and we've eliminated this constant transfer of data that can't be protected, and it's costing a lot. And it's this whole complex we just don't need anymore. So I think we need more independent doctors. I think it's in the natural course of events right now. To have that happen, we just have to figure out how to support them economically into those to go back to work for patients again.
So I think there's a little bit of a tension here that you bring up, right? Because you're clearly a proponent for independent doctors, but in order to bring the entire healthcare system to that proverbial single currency that you say, I think the only entity that has the power to do that would be the government, right? So there's like that tension of having more government control to have elements of a single payer system where you could have a single administrative bureau rather than all these silos. But that is clearly in tension with the independent physicians. So what do you think about that?
So first of all, the federal government is already has their hands in healthcare. That's what the Affordable Care Act did. But the healthcare dollar by the federal government is giving to middlemen. So 48% of the federal budget, 75% of the healthcare dollar is to middlemen. 48% of the federal budget's healthcare. And a recent study said 69% of the revenue from private insurers is actually tax subsidized. So let's just say Medicare for all would be 80%, we're at 69%, Kevin. We're there. And it's just like, so the whole concept of Medicare, the government pays, we already passed that threshold. Okay. What we have to ask now is how that money's spent and who do we pay? Okay. And the currency concept isn't a single payer, it's a single payment. It's just standardizing the bloody system so that you can't have 15,000 different dialects and languages and currencies. That just confuses people and confuses providers, it confuses doctors, it confuses patients. And there's a cottage industry built around those token exchanges. And you can't secure that data. So that the government can decide that the healthcare dollar is this and what it can be spent on, because the government has already decided that healthcare dollar. They've already given it away, but they're giving it to insurance, Medicare Advantage. That's their solution to Medicare. Keep everybody permanently 64 and give your Medicare dollar that you've earned your entire life away. I actually did the math on this and I said, what would you need your entire life from age 0 to 95? And these are actuarial insurance tables, right? And you know how much money you'd actually need? $875,000.
Wow.
That includes the kid in the NICU to the healthy person. That's all you need. And $875,000. And if you work every day from the age of 21 years old and you're putting away your Medicare 2.7% and you put it in the stock market at 10%, you take 3% out for inflation, you have about $600,000 by the time you hit 65, which will more than happily carry you through all of your healthcare expenses. So when we look at the math and see the finiteness of medicine, right? Suddenly the mystery should disappear, right?
Yeah.
There's plenty in the system today. It's just 75% of it is not paid to patient care. And the government is in control of that.
We're talking to Paula Muto. She's a vascular surgeon. Today's KevinMD article is Panic Button, Escaping the Broken Healthcare Escape Room. Paula, as always, will end with your take-home messages that you want to leave with the KevinMD audience.
So I think that I'd like to just say doctors need to not give up. We need to ask the questions, right? I think that we are the ones who have to get out of that escape room because we provide the service. And at the end of the day, the patients will listen to us first. And you cannot forget that, even when your day is terrible and you feel like you're getting beaten up by all the suits around you, telling you what to do. At the end of the day, you know that you're going to do what's best for your patient, and your patient will go along with that.
Paula, as always, thank you so much for coming back on the show and sharing your perspective and insight.
Thank you.